Hello, everyone. I am Dr. Cassandra Jimenez, and we are here again at Georgia Chiropractic Neurology Center. Today, we're going to be talking about one of the most common symptoms and conditions that we see in our office headaches and migraines. For the people that don't know me, I am a chiropractic neurologist. I hold a doctorate in chiropractic degree. I am a diplomate of the American Chiropractic Neurology Board, and I'm also a fellow of the American Board of Vestibular Rehabilitation. I also have the pleasure of being an adjunct faculty at a Life University where I teach neurology classes and motion palpation and adjustments. Here at Georgia Chiropractic Neurology Center, we are 7 clinicians. We have our own specialties. In the middle, we have Dr. Alice, which is the clinic director and the owner of the clinic. We are, as I said, have our own specialties. We like to co-manage the patients between each others to create a better experience for our patients and better outcomes as well. The most common causes of headaches that we see in the office are the following. We have central sensitization headaches. The brain itself doesn't feel pain. We're going to talk a little bit more later about it, but the system that processes the pain become overly sensitive. So your nervous system has become super or too reactive to the pain, and that's what we call central sensitization headaches. We also have cervical afferent dysfunction. These are the patients who have headaches because of their neck. Sometimes that comes because of trigger points on the neck, SCM, the traps. Sometimes you have headaches because of poor posture, degeneration, fixations on different structures on their neck. And that's something that we also take care of if a patient have a headache. Other causes of headaches are autonomic imbalances. We see a lot of patients with POTS, postural orthostatic tachycardia syndrome. Most of the patients that have that type of autonomic dysregulation or dysautonomia, they experience headaches are on the temporal lobe or the temples or the occipital area. We also have orthostatic hypotension because of drops of the blood pressure. So it's very commonly nowadays in our clinic. Vestibular mismatch is another common cause of the headaches that we see in our office. This is when we see now very commonly something that is called vestibular migraines. We see this a lot in patients that have a mismatch between the information that comes from your eyes, your inner ear, or your proprioceptive activity. When there's a mismatch between three systems, the patient tends to not know where they are in space. Sometimes these can cause some of the headaches as well. And it's one of the most common causes that I see in the clinic as well. Hormonal and metabolic triggers. Sometimes we see this if we need to refer for blood work or patients come with their lab and we see that there's potential for hormonal imbalances. We might refer out or we might do nutritional supplementation as well in the clinic. And lastly, we have tension type muscle overload, which is the most common, which is the tension type headaches, which are the headaches that are most commonly seen in the clinic. When we talk about pain, we talk about central, we need to understand what's the difference between central and peripheral pain. According to the International Association for the Study of Pain, pain is an unpleasant sensory and emotional experience associated with or resembling actual or potential tissue damage. And as I explained earlier, the actual brain parenchyma or the brain has no pain receptors. So we always say, okay, but how does the brain feel like know that there's pain? So we have headaches because the pain during the headache comes from structures around the brain, not the brain tissue itself. So some of examples of pain sensitive structures can be the meninges, the cerebral blood vessels. We have the cranial nerve. We have cranial nerve 5 or 10, which are very related to headaches. It can come from muscles. It can come from the scalp. So those are all tissues that have pain receptors. What happens if these tissues gets activated, and then you have, let's say they activated because of muscle tension or increasing intracranial pressure or any other cause. After they activated, you go in, and this information is transmitted into pain signals through the trigeminal nerve. Again, it's one of the nerves that sends pain into the face, or it can be the upper cervical nerves or other structures in the brain. Lastly, is processed in the cortex, where we have the thalamus, we have the somatosensory cortex, we have the insula, and then this becomes pain. So it becomes localized, it becomes more interpreted on the brain, and that's when we develop emotions. So we have the activation, we have the processing, and then um, we have the transmission, and then we have the processing of that information until it gets into the cortex, where we actually feel the pain. There are two parts of the pain. So it can be central, it can be peripheral. The peripheral, it's the most commonly that we know. So the peripheral pain can come from irritation or injury of the tissues outside the brain and the spinal cord. As I said, it can be from the neck, the scalp, joint irritations, inflammation of the sinuses, nerve irritation. And some of the time, or most of the time, when these tissues get healed, the pain goes away. So it's pretty straightforward. We also have central pain. So this is more brain-based pain. And this is the one that we see the most in our office because not a lot of people understand what central pain is. So this pain originates from how the brain processes and amplify the pain signals. So sometimes it starts from the periphery, so it starts from an injury or an inflammation, but over the time, the nervous system becomes more sensitive, and the brain continues to generate pain even after the tissue is healed. So we see this a lot in patients with neck pain, shoulder pain, or knee pain. These people have had this injury for a long period of time, that even when all the tissue it's healed, or there's no issue on the, on the musculoskeletal aspect of the shoulder or the neck, you still feel the pain, because now instead of being peripheral issue, now it becomes a central issue. So central pain is real, and it's super different to everyone. Same, it happens a lot with headaches, and that's why it varies so much in intensity, frequency, and triggers, because it's super individualized. That's why no two people are the same in our office. When we talk about headaches, we talk about, as we mentioned before, is a pain or discomfort in the head, face, or upper neck. And as we said, the brain itself cannot feel the pain. So the pain, because it lacks pain receptors, instant headaches occurs when the pain-sensitive structures, such as the nerve, blood vessels, or muscles surrounding the skull and neck, becomes irritated. So headaches right now are in the top five cause of disability adjusted life years. So it's on the top five, and it's very commonly seen in our office as well. According to the International Classification of Headache Disorders, or the ICHD, they have three different subcategories. They have the primary headaches, the secondary headaches, and now we have the neuropathies or facial pain and other headaches. And we're going to talk about the two different ones, the difference between the three of them. Primary headaches are headaches. The headache itself is the main medical problem, so no caused by any other underlying disease. These are 90% of the cases. These are the most commonly that we see in our office, because this is a functional lesion, not necessarily coming from secondary problems like brain tumors, for example. Secondary headaches are symptoms of another condition. So ranging from, it can be dehydration, but also can be super serious like tumors or strokes. Primary headaches, let's talk about examples. So we have tension type headaches, which are super common. These are dual aching pressure on the top of the head. It can be because of stress. It can be because of posture, muscle tension. It can be because of the tension on the neck or the shoulders. But it most of the time happens in both sides of the head. We have also migraines. Migraines account for 14% of the people get migraines. 8% male, 17 female. So it's very commonly to see this on females. And migraines always come with comorbid, like depression. Can be because of, it can come after a myocardial infection, so it can come with other issues as well. So migraines, they are neurological conditions that causes moderate to severe throbbing pain, and this often comes with other symptoms like nausea, light sensitivity, sound sensitivity, and sometimes visual disturbances. The third migraine, or the third type of headache that we see in primary headaches, is the trigeminal autonomic cephalalgia, or one of the subdivisions, which is the most commonly seen in the papers, are the cluster headaches. These ones are less common. These ones are caused very suddenly, very severe pain around one eye only, and occur in repeated cycles. So it can come from weeks, then go, and then come back after a couple months later. You can see eye redness, staring, nasal congestion with these attacks as well. So very commonly having tension type headaches. We also see a lot of migraines, which are the throbbing pain on the side of, often on one side of the head as well, and may last for hours or days. So that's the most what we describe as migraines. When we talk about pathophysiology of migraines, there's different things that we can say about the pathophysiology of migraine. Some people are just genetic predisposition. So some people are born with a more sensitive nervous system. Your brain just reacts more to strongly to stress, light, hormones, and lack of sleep. We also have cortical hyperexcitability. So your brain is a little bit louder than average. So normal things like light, noise, or stress feel bigger to your system. We, as I said, we call it also, and I have it on number 8, very very commonly, central sensitization. This is when, let's say that your car has an alarm, and that alarm should start gets on when let's say somebody breaks the window. But let's say that that alarm gets super sensitized, and then even when I touch the car, the alarms gets on. So that's why what we consider cortical hyperexcitability or central sensation. So you get super sensitive to touch or anything that it's supposed to, you're too close to that threshold. So let's say that your brain was used to go to a soccer field and being able to be around people and have a lot of noise and lights and everything was okay. But now because your brain is a little bit more sensitized, you get more flustered because with the same type of sounds. And that's one of the main reasons why people get headaches nowadays. We have cortical spreading depression. We have trigeminal vascular system and neuroinflammation. Um, Before we thought that the headaches were mainly vascular, but now we know that they're a little bit more neurological rather than vascular. There's a pain nerve that wraps around the blood vessels of your brain. And during a migraine, that nerve gets very irritated and releases inflammatory chemicals. And that is what causes like to have a throbbing pain on the site. When we talk about cortical spreading depression, that is mainly the aura. So some people have the aura, like they feel flashing lights before they get that headache. We also talk about thalamic sensitization, or let's talk about first brainstem dysfunction. These are abnormal activation of the brain region. So we talk about again the trigeminal nerve. We talk about cranial nerve 10, very related to headaches. This is one of the main things that we see in our office as well. When we do our physical examination, we see and we check all the regions of our brain. So different lobes of the brain, brainstem, midbrain, pons medulla, cerebellum, vestibular system, and then we come up with the areas of the brain that might be causing those headaches or those migraines. And most of the time, we see very commonly the brainstem dysfunction. Thalamic sensitization. This is the thalamus is the area of the brain that is the sensory filter. So in this case, it becomes too sensitive. So that's why your skin hurts to touch, your hair hurts, or life feels like unbearable. So it gets super sensitive. And we also have the autonomic nervous system dysfunction. We talked about POTS earlier, or orthostatic hypotension. So the migraine actually starts before the pain. And this happens a lot when we, let's say, the part of the brain that controls the heart rate or the blood pressure, um, it's not working as it should. And most of the time, patients with autonomic dysfunction not only comes with pain, but also have nausea, have sweatiness, congested dizzy. This is the people that have cold, clamming hands. These are the people that have gets red or dizzy when they get into hot showers, or they have temperature dysregulation or constipation. So these are the people that have issues with heart rate and blood pressure, and also because of it, they get migraines. I like when we talk about neurology, we like to talk about the bucket theory. A lot of one of our mentors talk about the bucket theory to explain migraines. We have most commonly three reasons why you might have a migraine. It could be hormonal, it could be musculoskeletal, it could be neurological. So in our physical examination, we need to say, is it neurological, is it musculoskeletal, or is it hormonal, what is causing your symptoms? So migraines are like a bucket. So every patient has a bucket. It's the brain capacity of that patient. Stressors, water filling the bucket. So let's say when the bucket overflows, your symptoms occur. So what type of stressors can you have? So you can have poor sleep. Let's say that not only poor sleep are going to cause you have a headache. So let's say that that day you have poor sleep, you didn't eat well, and you didn't drink water. And then on top of it, you were having poor posture when you were on the computer. And then on top of it, you have a lot of work pressure because your boss is on top of you. And at the same time, you are developing food sensitivities. And because of it, you start developing a migraine that day. So all the stressors are different for everyone. You can have physiological stress, you can have mechanical stress, sensory stress, emotional stress, neuroinflammatory stress, and all of it can be super different for everyone. So when we are here in our office, we need to check for those triggers and then try to modify as we go on the treatment. We talk about secondary headaches. We have a couple on when we on different papers, but one of the most common ones are concussions. We see this a lot after traumatic brain injuries and concussions or coming from the neck. Patients can be not only having the headaches, but can be having dizziness, light sensitivity, nausea, difficulty concentrating. We in our office, we it's very commonly to see headaches after concussions. That's one of our specialties, and we do really well on it. Another secondary headaches are brain tumors. This is a red flag. So when a patient comes from for the first time, they're having a headache, and we do our physical, and we think that must be something else that might be causing the headaches. We send them out, let's say for an imaging, MRI, CT, depending on what they need, and then we make sure that that's not the cause of the headache. Medication overuse headaches, that's something that is very commonly seen in our patients. Um, Unfortunately, some of the patients are in 10, 15 medications by the time they come to us. And we see that very, very commonly, where there's like side effects from medications for the dizziness or side effects for the medications for other symptoms that they have, and they start having headaches. We can have headaches for psychiatric disorders, substance abuse, let's say strokes or hemorrhage. You can have headaches as well. So you need to make sure that you know why you're having a headache, and you know how to differentiate red flags and not red flags for you to refer out if you need the most. Um, we're done with primary and secondary headaches, but we also have the refer headaches, like, or other headaches. We have trigeminal headaches. These are we have a trigeminal nerve. So if you see in the picture, it's caused by irritation or overactivity of this trigeminal nerve, and this might cause like a lot of sharp stabbing or electric shock, like on in the face. Some people have jaw pain or pain around the eye. You can have pain on touch on the face or the scalp. And it happens just because of overly sensitive nerve. It can be because of after a major injury. It can cause after a concussion, a virus infection. I've seen it as well. So that's one of the type of headaches. And we also have occipital neuralgia, which is very similar, but instead of the trigeminal nerve, it happens on the back. So these ones are the occipital nerves around that area. And these cause shooting, shocking, throbbing, burning sensation on the back of the head. Vestibular migraines, I wanted to talk a little bit about it because, again, it has been very commonly seen in our office. Is very underdiagnosed. And now it affects maybe 1 to 2.7 of the general population. But the clinical presentation of vestibular migraines, sometimes you don't need to have a headache to have a vestibular migraine. But when we talk about the diagnostic criteria, which we're going to talk about in a second, at least 50% of the episodes of vertigo are going to be accompanied with a migraine or a headache. So, most of the time, neurological examinations are unremarkable, but during acute attacks. So, sometimes I see patients that have headaches. I see patients that I feel they're going to be diagnosed with vestibular migraines, but they don't have symptoms and the physical looks pretty good. So what I do is I tell them sometimes if you have a vertigo, I want to see you again. So to see how it looks your physical compared to your baseline. The diagnostic criteria that is proposed by the International Headache Society and the Committee for the International Classification of Vestibular Disorders of the Barani Society, they say that to have at least 5 episodes of vestibular symptoms of moderate of severe intensity, so lasting for 5 minutes to 72 hours. And it needs to come with a migraine at least 50% of the time. So you can have nausea, you can have light sensitivity, noise sensitivity, but just so you know, not all the time that you have a vertigo, you need to have a migraine for you to have a vestibular migraine. So it's super important. Very commonly seen in females. And it's very commonly seen with, it has both environmental and genetic factors that can be causing some of these migraines as well. So, how can we help in Georgia Chiropractic Neurology Center? We have different symptoms. After we do our physical examination, it lasts 3 hours. We look at your cognition, your balance, your vitals. We look at your full neurological examination. We pinpoint the areas of the brain that might be affected. As I said, it can be the neck, it can be your vestibular system, it can be some areas of your brainstem, it can be related to hormones. So after we know what part of the brain is the one that is causing your symptoms, then we create a treatment plan for you. So that how does it look like? We can do vestibular rehabilitation, eye training, we can work with trigger points, myofascial release, we can do chiropractic care, craniosacral work, autonomic regulation if you have POTS or if you have orthostatic hypotension or if you have any issues with your autonomic nervous system. Let's say that when you go from seated, laying, and standing, your heart rate jumps. We might try to help you with that. Can be on the tilt table to decrease the amount of headaches that you're having. It can be with nutritional support. So depending on the cause of the headaches and depending on what is going on or what is the dysfunction of your brain, then we create a treatment plan specifically for you to help your patients or help your headaches. I'm sorry. So treatments. We can do eye movements, as I said. In the second, we have tilt table therapy for patients with dysautonomia. We do gaze stability exercises or vestibular rehabilitation, eye exercises. We can do coordination exercises on the fourth picture, and then we can also do balance. We can do eye head coordination exercises as well. So, again, it depends on what part of the brain is the area that is affected. And based on that, we create a specific treatment for you. Last one, I want to talk about trigger points because most of the time, sometimes when we think about coming to the clinic, we always think about, oh, let's crack their neck or let's just adjust or let's just do vestibular rehab. But we also sometimes check for trigger points, or most of the time we check for trigger points. Some trigger points that cause headaches, it can be the traps, your suboccipitals, your temporalis, SCM, your levator scap. So we check all those trigger points to make sure that those are not the ones that are referring to your headaches. We also do myofascia work as Dr. Wright is doing in this picture. in case this is one of the reasons why you're having the headaches. And not a lot of people know about the trigger points, and this is something that we do very often in our clinic. So the treatment is very individualized from patient to patient. It depends why you're having the headaches or your migraines and what is causing you. And our goal in our physical examination is discover why you're having your headaches or your migraines, and again create a treatment plan individualized for you. That will be the final of my presentation. You can schedule a complimentary consultation today in our clinic. You can email our office, you can call us, or our website is healthybrainnow.com. It has been a pleasure. And then again, if you have any questions, you can always contact us. Thank you so much. See you in the next one.